Hello, everybody. We are here to study some virtual slides I've selected from Pathology 1 laboratory exercises, numbers 4 to 8. So where would you like to start from? Shall we start from an easy chapter? We'll start from the skin then, okay? Yes. Okay, we'll start from the skin. Okay. Your the attendance today is optional, so everybody can come, everybody can leave, no problem, okay? So let's see. I cannot see the whole screen. Elena, can you tell Christos to come? Not all slides are present on the screen. Tell him to come. Some of them. Shall I start? Oh, it's like, they gradually they appear. Start from the skin and go backwards. Okay. Now. This one. All right. Now, what do we see here? So this is the multilayered, squamous, keratinized epithelium of the epidermis. So in any skin lesion, we have to see where the lesion is. Is it in the epidermis? Is it in the dermis? This is the dermis, papillary dermis, quite superficial, and the reticular dermis, deeper. And is there anything next? Yes, and you can see adipose tissue. You see that we have inked the specimen. Why do we this? Why do we do this? We do this so as if we have a neoplasm, we want to count the distance of its deeper part from the surgical margin so that to see that it is well excised and it won't recur. So now in this field, what do we see something that is abnormal? In which part of the skin? In the epidermis or the dermis? What do you think? The dermis. So we'll just look at the epidermis quickly. Is there something different here? Yes, you see that what are these cells here? Which layer of the epidermis is the one I'm showing you? Which one is this? This is the basal layer. In the basal layer, we have melanocytes and the basal cells. Can you see something that is quite strange here? There is too much melanin in the basal cells. So this is a feature which has to do with the diagnosis that also makes us take into account that if we have a pigmented lesion of the skin, it is not necessary that it comes from melanocytes. It can also derive from basal cells because there is some melanin in basal cells as well. However, in this lesion, there is too much melanin. Okay, we see the other layers, squamous layer, the granular layer, and the keratin layer. Everything is fine. Now, what do we see here? We see that there is an area in the dermis which, how would you describe it from its color? What would you say that this area is? What do you think? What color is it? Yes, it's purple. That means there are many cells there with nuclei. That's why it has this color. So let's see these cells, because these are the cells of the lesion. Here it is, here the dermis is quite clear. Here there are many, many cells. And you see, some of them come around these fascicles of collagen quite deeply. So let's see the cells. Now, I want you to identify their shape and tell me of which tissue are these cells having this shape, which is the most possible source of these cells. What do they look like? How do we describe this? How do we describe this shape of the cells? What do you think? Spindle cells. That's right. So they come from mesenchymal tissues, connective tissues, smooth muscle tissues, neural tissues, something like that. Well, in this case, they are some sort of either fibrohistiocytic, some sort of a mixed phenotype. So they are from connective tissue. Now, as you can see them, do you see some signs of malignancy? That means atypical nuclei, enlarged nuclei, hyperchromatic nuclei, nuclear pleomorphism, many mitosis. Do you see any of these features that would make this neoplasm look malignant? No, because the cells look like each other. They are all spindle cells coming from fibrous tissue, so it looks benign. However, it might have some sort of pseudo-invasive here border, because being of mesenchymal nature, its margin is not so well demarcated. However, in this case, this is not a sign of malignancy. Okay? This is a benign lesion. So how would, in terms of terminology, how would we term a benign neoplasm coming from fibrous tissue, from fibroblasts? How would you say that? How would you diagnose this neoplasm? What do you think? We can come this way now. Here we are. It's a fibroma. So this is a dermatofibroma. That's all. It's well excised. It might not be neoplastic. It might be of reactive agent, possibly in areas of the skin of the lymphs where you have some mosquito bitings, then this can come. I'm not sure it's neoplastic. But anyway, it's benign. That's the first one. So, next. This one. Oh, yes. Look. Here we have a lesion, and a main feature, this is a lesion of the epidermis. Okay. And I want you to identify how it grows, the pattern of this lesion development. Now, let's have a look at the normal epidermis. You see the keratin, the follicles? All right. And I want you, let's come to the other side, like here. And I want you to tell me if this lesion, you understand the lesion, grows on an exophytic pattern or an endophytic pattern, meaning that is it below the level of the normal epidermis, or does it grow upwards in an exophytic way? What do you think now that you look at it? You see, I have shown you the level of the normal epidermis. So how does it grow? Below means here, below the level. That would be an endophytic. Yes, but have a look where the level of the normal epidermis is. You see the normal? So this is normal. It's not here. That would be an endophytic pattern. You see? Why are you so... What's the problem? It grows up. What's the problem? What's happening? It's easy to see. It's no problem if you make a mistake. I make mistakes all the time. No problem. The question is how to understand and make this, and don't make the same mistake too many times. Okay, you can do it twice, 3 times, but not more. About 3 times it's okay, till you learn it. So you see the level of the epidermis. This is upwards. This is the level of the epidermis here and here. You see the two levels of normal epidermis. So it grows upwards. Now let's have a look at the cell. What are these structures here? You see, they have a fibrovascular core. You see? The core, the fibrovascular core. And these stalks are lined by cells of the epidermis. So, what are these called? What are these structures called? You see, they're like fingers, finger-like projections. How are they called? You know that? How are they called? Yep, tell me. Papillae. Yes, these are papillae. So, this is benign because it is composed of cells of the epidermis showing no nuclear pleomorphism, no signs of atypia. So, how do we call the benign neoplasm with a papillary configuration? How do we call it? This is a papilloma. Yes, and if the majority of cells are dark, that would be a basal cell papilloma. That's known on a clinical context as seborrheic keratosis. That's the clinical term. I'm not sure that it is so accurate, because if we look at the cells, the basal cells most times predominate, and they are more than the squamous cells. So, let's have a look at the cells. You see here they are somehow, you see that they have some color, a brown color. That's due to melanin pigment here in the basal cells. And you see that it makes some downward projections here, despite its exophytic nature, which, however, are very well circumscribed. You see how well circumscribed they are? So they do not appear to be invasive, because anything that we see that grows in the dermis is not necessarily invasion. It might just be an endophytic component. Anyway, this is an exophytic lesion composed by epidermal cells, mainly basal cells, but some squamous cells participate in the lesion as well. I can see that we can identify them. Yes, these are squamous cells. You see? The squamous cells, here they are. And so they have some cysts here, which are filled from a material that I'm sure you know, you can identify. What material is this that appears to fill all these small cysts? What is this? Have a look at the surface of the epidermis here. We see the surface of the lesion, and you see here these, yes, this follicular somehow, and it's the same here. So what substance is this that we see in the cysts, that we see on the upper layer of the normal epidermis? It's keratin. So these are keratin pseudocysts, because they are not true cysts, meaning that they communicate with the surface. However, this continuation is not always evident in the sections that we examine. So the dermis is totally clear. Here we see the endocrine glands, some vessels, the adipose tissue. So is it well excised? Yes, because here that we have this margin, I do not see the lesion. This is normal dermis with sebaceous glands near hair follicles. The other margin is perfectly all right. The deeper margin is, of course, all right, since it is a benign lesion and it does not invade. So this is the seborrheic keratosis. And here we have something that we wanted to show. Let me see what this is. No, I think yes, this has to, you see how brown these basal cells appear? Yes, remember that I told you that basal cells may have melanin accumulation. So this is a benign neoplasm, a seborrheic keratosis. If you look at it macroscopically, it's like a gum that you have chewed, and it's on the screen, on the skin. It's exophytic. Okay, next one. Let's try this one. So, this is quite different. However, in this magnification, it appears to have an exophytic pattern. So, when we see an exophytic lesion of the skin, it is not always benign. It's not always benign. It can have an endophytic component and an invasive component sometimes. So anything that appears to grow in an exophytic way is not necessarily benign. We have to check what's happening on its stroma, on the connective tissue within this neoplasm. Because if we look at this lesion on a small magnification, of course, it seems to be exophytic, so it may be benign. However, yes? Okay, want to ask me something? Ah, yes, okay. Is it the cold? Does it affect the air condition? No. So, let's have a look. Is there another section? No. So, this is the normal epidermis, and this lesion is clearly developing in the dermis, and I want you to tell me which cells of the normal layers of the epidermis do these cells resemble? Do they have much cytoplasm? That means, are they pink? Do they stain with eosin, the pink staining of the cytoplasm? No, they appear purple. So they have little cytoplasm. Which cells of the normal epidermal layers have normally, they're normal cells, have little cytoplasm because they are somehow primitive cells because they belong to the proliferation zone. And they proliferate all the time, and some of the cells go upwards and they get cytoplasm and they mature under normal circumstances. What cells do they look like? Tell me. Basal. They're basal cells, all right, of the basal layer. That's why they're so dark staining. And if we see at the periphery of these downward projections, proliferations, you see that they appear somehow, one cell being very opposite to the next one. That means it has a pattern of a pathology pattern, like one cell like the other, just like normal basal cells do. They are some sort of stratified one next to the other. Let me see where I can show that, and it will be clear. It is at the, you see here? Here they are all mixed. No polarity is evident here, but here they appear to be one next to the other. And what do they do? What is this cell here? In which phase do we find it? This one, this one, this one. Oh, too many, I see. What are these? Yes, yes. But, my dear, there's no need to come on Monday because there are too many. Just remind me at the end of the lesson if you know everything already. Yes, there's no need everybody to come because there are too many. Oh, 30 people on the next, that will be next Tuesday, I think. Yes, you can go and start your swimming. It will be a three-day holiday. It's not necessary to come. Some of you, it's okay to get. I'll examine you now in the lesson. Oh, no need to come on Tuesday. All right? There's no need. So yes, these are mitoses. So it's a mitotically active neoplasm. So how you can see that the way it grows in its stroma, because I'm not sure that we can talk of the dermis. This appears to be the stroma of the tumor. At least in some areas, is not so regular. Would you describe all these small projections of neoplastic cells within its tumor as being benign endophytic projections? No, it appears somehow invasive, Of course, the cells, they have some degree of pleomorphism. They are all spindle cells, basal cells. They have increased mitotic activity. So you see here all these cells. This could be invasive. It could be invasive. You see it grows downwards, even though the whole skin is elevated due to the neoplasm formation. It has an exclusively endophytic and invasive pattern, not just endophytic, because everything that is endophytic is not malignant. But if we have invasion, this favors malignancy. So this is an invasive tumor with increased mitotic activity of basal layer derivation. So since it derives from basal cells are part of the epidermis. So they are epithelial cells. How would you call a malignant neoplasm deriving from epithelial cells? Who else wants to be examined? How do we call it? Okay, it's okay. You can not come. You can go and have the bath during the 3-day holiday. Okay, this is a carcinoma. And since they are basal cells, this is a basal cell carcinoma. And this diagnosis is very clinically significant because such tumor have a minimal metastatic potential. That means if they are well excised, the patient is cured. He forgets them. So that's a basal cell carcinoma. Now, let's have a look at this lesion. This appears to be a lesion of the epidermis. Okay. Is there something you remark here that is abnormal and we can see in this low magnification? Is there a layer of the epidermis that looks some sort of thickened or abnormal? Which layer here appears to be rather prominent among all the other layers of the epidermis? Which one does it appear to be more prominent? Its thickness is more than all the other layers. It is so hyperplastic, I'd say, that its thickness exceeds the thickness of all other epidermal layers. Which one is this? Tell me. Want to show you in higher magnification? Here it is. This one. Look how thick it is. And it has this nature you see here. Which is this layer? It's keratin layer. However, since we see the nuclei in the keratin layer, this is not orthokeratosis, this is parakeratosis. All right? So we have an area of parakeratosis, which in some places, look here. It changes here. Here we have parakeratosis, very thickened layer, and here, do you see nuclei here? No. We just see keratin material without nuclei. So this is, however, this area is also thickened. It's very thickened. So this is hyperkeratosis. Hyperkeratosis. So in the surface of the lesion, we have an alternation between areas of parakeratosis and hyperkeratosis, orthokeratosis. This is a diagnostic feature of the entity we are going to diagnose. Now, let's have a look at the other layers of the epidermis. So which one is this layer? This is the basal layer, and this is the squamous cells, which are more mature. I want you to see here, bless you, the thickness of this basal layer by comparison to the thickness of the keratinocytes, the ones that they have cytoplasm. Which one do you think that it is increased? The layer with the mature keratinocytes or the layer of the basal-looking cells? Which one do you think? The basal layers should be close to the basement membrane. If we see cells similar to the basal layers extending upwards, that means that the primitive compartment, the stem cells of the skin, start to predominate among the other cells. And this might be a feature that some sort of malignant potential increases in these cells. Under normal circumstances, there would be one layer of cells close to the basement membranes because they give rise to the keratinocytes, which, as they go upwards, they have they acquire cytoplasm and they mature. In this case, maturation is not enough because we see an extension of basal cell-like cells which, being primitive, have not enough cytoplasm, so that's why they appear dark in hematoxylin eosin. So this could be, have a look here, you see they have some nucleoli, they have some atypical features, some loss of orientation, while the squamous cells which remain here are growing parallel here lines. However, these cells occupy an increased part. See how many they are? Too many. And you see how the keratin cells are few. So this might be a sign of a population of cells with a malignant potential, which, however, is not cancer. Why is it not cancer? They do not invade. They do not break the basement membrane and go into the dermis. So there is no invasion. So remember from our general courses of general pathology of neoplasia, how do we call an intraepithelial, a pre-invasive neoplasia? What's the term in pathology to describe these cells? They look malignant, they may have a malignant potential, but at the present time, they do not invade. So how do we call them in pathology? What did you learn? Pre-invasive neoplasia. They are not cancerous cells. Why? Because they are devoid of the hallmark of malignancy, which is invasion. So how do they call them? How do they call them, these cells? Oh no, if you don't know that, I'm not passing the exam. Cannot pass because this is very fundamental, and if I didn't manage to teach you that, that means that I fail. So please find it, please, find please. This is pre-invasive neoplasia. That means if you leave it and don't excise it, they may become malignant, they may invade, and if all cancers were diagnosed at this stage, no metastasis would ever occur. Why? Because there is no invasion. Okay, I'll help you. Please have a look at your notes on the lesson of neoplasia. I want you to find this because it is very important in pathology. Oh no, I have to repeat all the lessons from the beginning. Well, no, it's not so bad for me. I don't know for you. It's okay. I'll manage, I think. But I'm not sure what about you. How we can tolerate that? Because just tell me, please. You know it. It starts from. Tell me the first letter. Don't make it wrong. What does it start? Thank you. It's dysplasia. This is dysplasia. All right, we won't repeat all the lessons from the beginning. Good. Because it is very typical, because I know you want to focus your brain. Your brain focuses in about, now we have about a lesson of half an hour. Right? There are 2.5 hours more to go. But I understand that you can focus your brain on a subject in about 1.5 minutes. Because that's how long the TikTok videos last. Yes. However, yes, okay, yeah, I know. Everybody does that. Yes, I know. But here, we're not exactly doing this thing. We're having a 3-hour lesson. Okay. Everybody who is tired can leave the lesson. No problem. It's optional. He can watch it in part from the channel because we have the online transmission. I hope that this is active. So, let's go on. So this is dysplasia, and have a look at the dermis. You see here the dermis? Look, is this area of the dermis, this is the papillary dermis, the superficial dermis. Is this area normal? No. This is an elastosis. This is basophilic degeneration. That means that this skin is so sun exposed, and there is so much damage from the sun that when we see that in the dermis, that it looks older even than my skin. See? It looks older even than my skin. That means this is a lesion that has to do something with the damage caused by the how is that, the radiation of ultraviolet? Yes, by that radiation of the sun. So, and what else do we see? Because all this is happening in the epidermis, look at these cells that have come. What are these cells? They're lymphocytes. The immune system got it that there is something wrong in the epidermis, so there are also some lymphocytic aggregates in the dermis. And all this pre-invasive lesion is called solar or actinic keratosis. So what do we see here? We see the dysplasia, no signs of invasion, the basophilic degeneration of the dermis, the lymphocytic infiltrates, and the thickened superficial layer of parakeratosis, which is, in some areas, it transforms to areas of hyperkeratosis. This is parakeratosis, this is hyperkeratosis. That's all. Yes, please. The solar elastosis. The solar keratosis. Yes. That's either solar keratosis or actinic keratosis. I think it has two terms. Okay.
Professor?
Yes.
When would we call the dysplasia carcinoma?
When we see invasion through the basement membrane. If they go in the dermis, then it has been the malignant transformation has occurred. They start invading. Here everything that has happened within the epidermis is intraepithelial neoplasia. No malignancy, but it has a malignant potential. Now, let's have a look here. So, now, this is the normal epidermis, the normal, all right, the normal epidermis. And what do we see here? Oh no, this is an area. Do you see epidermis here? No, we just see increased vascularity with too much blood, and in another area, in this area of the destruction of the epidermis, we see some inflammatory cells. Can you identify them? What are these cells? Look at their lobulated nuclei. They are neutrophils. So this is an area of acute inflammation. Okay, there are some mononuclear cells as well. These are lymphocytes. And there are some lymphocytes which have this morphology. Can you identify them? Do you remember them from the inflammation lessons? Excellent. These are plasmacytes. You can start your bath, your sea bathing next 3 days. It's not necessary to come on Tuesday. Not necessary. You know the plasmacytes. So how do we call that? What is this? We have a destruction of the covering epithelium of the skin. That means we have a destruction of epidermis, and it has been replaced by some sort of necrotic material in which we see inflammatory cells, neutrophils and mononuclear cells, a mixed inflammatory infiltrate. How is this called? How did we call this from our lessons on inflammation? That we have a destruction of a covering epithelium and its replacement by this, I would say, this some sort of pus, an exudate. How do we call that? Then? Ma? How do you say that? No, that means it changes to another type of epithelium. That is metaplasia. That means we have an epithelium and it is not destroyed, but it changes to another type of differentiated tissue, but of another type. So what do we call this? If you see my skin and it's all red and all the skin has been destroyed, and you see, sometimes you see granulation tissue, inflammatory granulation tissue growing on the deep part of this destruction. How do we call this? An ulcer. Yes, this is an ulcer. All right. So when we see an ulcer, it might be either due to inflammation or due to cancer, because cancer destroys the mucosal epithelium, the superficial mucosal epithelium, or in the present slide, the epidermis. So let's see downwards. So what is here? Now, we have cells growing downwards, and we'll try to see the features of these cells. Yes. Now, you see in these projections that the cells are atypical because the nucleoli in their nuclei is quite prominent. However, they retain an amount of cytoplasm which helps us identify these cells to which similar benign cells of the epidermis, which layer is composed of cells that look like these, however, they are not so atypical in normal epidermis. Since we see that these cells have an amount of pink cytoplasm, we can identify them as cells deriving from which layer of the epidermis? From which layer? Yeah.
Maybe
the basal, they would be darker, like the basal cell carcinoma. You remember the previous one, that they all appeared purple, dark?
Developing layer from
the one that is after the basal. That means that the one that there is some sort of maturation in the context of pink cytoplasm acquisition. So, these are, which cells are they? Squamous. These are squamous cells. Yes, and there are some other sides of squamous differentiation, like this one here. You see, this is a single cell which is keratinized. That means it has entered the apoptotic process, and we no longer see its nucleus. So this is dyskeratosis. This is some sort of keratinization without showing the pearls of keratin that we would expect to see in a squamous cell carcinoma. So there are some signs of keratinization, but this one, have a look. Have a look at this cell. You see how it is shrinked, both the nucleus and the cytoplasm. So how did we call this? We called it dyskeratosis. So this is, and this one as well. What about this one? What denotes here that this is possibly a malignant cell? What happened to its nucleus? Have a look. What is this? It could be either a mitosis or a, how does it call that? Karyolysis. That means the nucleus breaks. I'm not so sure what of the two. However, it is not normal. And in these downward projections, the cells have no proper orientation. Remember how calmly the cells grow in normal epidermis. They grow in parallel lines. Here they are all mixed up. So it grows downward. So this is a sign of invasion. And here is the immune reaction against the invasive cells. And despite there is not pearl keratins formation, that means evident keratinization, we managed to see that these cells derive from squamous cells. So it's invasive, it's atypical, it derives from squamous cells, so it is a squamous cell carcinoma of the skin. And in contrast to basal cell carcinoma, squamous cell carcinomas can give metastasis, mainly if they develop on areas of where the skin was burned. They have an increased metastatic potential, these specific squamous cell carcinoma cells. So in this case, the difficult thing is to define squamous differentiation, because I do not see the hallmark of squamous differentiation, which, however, would be easily observed in well-differentiated squamous cell carcinoma. That means if you see squamous cell carcinomas filled with keratin pearls appearing similar to what we saw in the seborrheic keratosis slide as pseudocysts. Remember that material that we saw in the seborrheic keratosis? If we saw that within the neoplastic population, we would say this is a well-differentiated squamous cell carcinoma because it keratinizes widely. Now, it's not the case here. However, we managed to understand that these cells are of squamous derivation. So, which grade would you apply to this squamous cell carcinoma? We managed to understand that it derives from squamous cells because we saw pink cytoplasm in the malignant cells and areas of dyskeratosis. That means keratinization of single neoplastic cells, not forming keratin pearls. So which grade do you think? Low grade would be high differentiated. That means it would be filled with keratin. It would be filled. Which one? The moderate is correct, because I cannot say it poorly differentiated, that means high grade, because in such tumors I would use immunocytochemistry to define that it comes from squamous cells. I would use markers of squamous cell differentiation because morphology would not help me to define the nature of the cells, such as P53 or P40. These are markers, immunomarkers of squamous cell differentiation. However, they are not necessary here. Why? Because this is moderately differentiated, is of intermediate grade. Grade 2, squamous cell carcinoma. It's well excised. You see here, we have skeletal muscle here. It's free. Adipose tissue of the subcutis. Some nerves, peripheral nerves. Of course, we can count how the deeper part of invasion, that means how millimeters is that from the surface. And remember that being malignant, it ulcerated the normal epidermis. And of course, it has an entirely invasive endophytic, but not just endophytic, invasive front. These parts of the neoplasm being down there, of course, they have a round contour, which is not so compatible with invasion. However, you can see that they are quite separate from the main tumor mass. So, this is an invasive lesion. And we have here, somebody noted here that we have some sort of nuclear pleomorphism. I think that it is quite evident here. We have hyperchromatic nuclei of different sizes and shapes. So this is a squamous cell carcinoma. Another annotation, let's have a look, what's here? What are these cells? I'm not sure. What are these cells? And, yes, this is dyskeratosis. Okay, we saw that. And if we had no dyskeratosis, just the pig cytoplasm, how would we suspect that it derives from squamous cells? Have a look at one cell with malignant cell with one next to it. What are these? You see? What are these? Have a look here. And this is a sign of squamous cell differentiation. What do you think they are they? You see? What are they? Those were hemidesmosomes in the electron microscope. These are intracellular bridges. And when we find that in a malignant tumor, this is also a sign of squamous cell differentiation. Okay.
Professor?
Yes?
Macroscopically?
An ulcerating neoplasm, which would be suspicious for cancer, just because it was ulcerated. When you see an ulcerated lesion, you ask the patient, did you do it yourself? That means, did you put something on and you have made the ulceration yourself? See, no, it was spontaneous. It happened on its own. It started bleeding, that means, and destroying. This is a sign, very suspicious. If you are not sure, you can take a biopsy from some part and send it to the pathologist and say it's cancer, and then you will he will define the type of cancer, hopefully. And so you'll know how the margins, how many millimeters you'll have to cut so that it is fully excised. They are not all the same. They are not the same for melanoma and carcinoma. No, they're not the same. Yes, please. Yes. Yes, please.
What are the signs that we should look for histologically for
For
the squamous cell?
the squamous cells, pink cytoplasm. In the specific tumor, pink cytoplasm of malignant cells, dyskeratotic cells, and intercellular bridges. In this slide, these three features define squamous cell differentiation. And it is not so well differentiated to see keratin pearls, not so well. It is of intermediate differentiation. And here is invasion, irregular projections in the stroma. You see how irregular they are? So it appears invasive. Next. This one. Oh, very nice. So have a look at the lesion. This is the lesion. And we can see that mainly it grows in the dermis. And from low magnification, a very important feature, especially for this sign of lesion of the skin, this sign of tumor, is the symmetry. That means that there is symmetry of this lesion. If you fold it, one half of the lesion falls to the other part of the lesion. Why do I say this? I say this because, can you see signs of differentiation defining the cells making this lesion? It's very easy. What color are the more superficial ones? What color are they in the microscope? What color are they? This is a sign of differentiation. What color are they? They are brown. Which is the brown pigment of the skin? Which one is it? So they are melanocytes. We'd better call them nevus cells. Why? Because they are benign. They are benign. That means, what are the signs of benign? They have no, look here, they look quite the same, one to each other, and more importantly, as we go on the deeper parts of the nevus, the intradermal nevus, because it's within the dermis, the nevus cells are within the dermis, we can see that they grow somehow smaller. This is a sign of maturation that a melanoma would not do. And especially, you see the cells? Here, look at the cells here, and look at the ones in the deeper part of the nevus. You see they are smaller cells. This is evidence of maturation. This would not be present in a melanoma. In a melanoma, you would have atypical cells from the upward to the downward part of the tumor. Here, there is evidence of maturation, and more importantly, in this deeper part of the nevus, no mitosis are discernible. So, the main features to differentiate an intradermal melanocytic nevus is this one, intradermal. Let me see, does it have a junctional component as well? That means, do we see nests of melanocytes within the epidermis? No, I don't think so. Here there are separate melanocytes. They are not nests. So it is an intradermal nevus, because you know, in terms of terminology, if we see nests of nevocytes within the epidermis, then we call it, how's that? Junctional nevus. If all the nevus cells have migrated to the dermis, this is an intradermal nevus. And if the nevus has both a junctional and an intradermal component, we call it a compound nevus. Here we have a case of intradermal nevus with evidence of maturation, and no mitosis on its deeper part, either in its deeper part or, in the present case, in the superficial part. So this is a symmetrical, totally benign nevus, and I can see that it is well excised. Some marks here, yeah. Here is, always pay attention. If you see melanin, you always have to differentiate it if it is a sign of melanocytic differentiation. That means it would be fine granular. If you see coarsely granular melanin, this is not a sign of melanocytic differentiation. These are macrophages which have taken melanin. So, when we see melanin in a lesion, we have to define, is it a sign of melanocytic differentiation? It must look finely granular, like the ones we saw in the beginning, here. Here is the case. You see what fine granular means? You see here? This is a sign of melanocytic differentiation. This is not a sign of melanocytic differentiation. Why? Because it is coarsely granular. If you see coarsely granular, these are macrophages. There's no sign, this is no sign that the cells derive from, that the tumor derives from these cells. So, if we want to see melanocytic differentiation, the pigment in the cytoplasm of neoplastic cells should be fine granular. Okay? Good. And our last case, what's happening here? This is a lesion protruding from the epidermis. Look what it's done. Look what it has done on the surface. There is no epidermis. What has it done? These are necrotic cells. So this is an ulcerated lesion. And which cells came here to the place of destruction? Can you identify these cells? I'm sure you can. You have neutrophils. Yes, because why? Because there is destruction. So neutrophils came. So this is an ulcerated lesion. It showed spontaneous ulceration. And let's have a look at the cells growing deep in the dermis. Can you tell that they are melanocytic from this melanin presence? Is this a sign of melanocytic differentiation? No, because it's too coarse. I'm not sure, because in some cases there is some sort of melanin going from the basal layer to the dermis, and macrophages go and phagocytose the melanin. So I do not think that this is melanin, but it is not in the melanocytes. But these are not melanocytes. So let's have a look at the other cells, not the melanophage, not the macrophage. Of course, there is evidence of malignancy here. because nuclei are pleomorphic. This one is big, the other one is small, of another shape, and in many cells, nuclei have grown and outgrown the amount of cytoplasm, so there is nuclear atypia, increased nuclear atypia, and we have the necrotic activity evident in the ulceration of the epidermis. So if we want to define and be sure of the derivation of these cells, we can perform immunohistochemistry with melanocytic markers, and then all these cells will be stained. So we'll understand that the markers of melanocytic differentiation is melan-A, MART1, HMB45, and I think also SOX10. So if you want to be sure, you are not sure that these are melanocytes because you saw coarsely granules of melanin, so you are not sure that the melanin is in the malignant cells, you perform immunohistochemistry and define these cells as melanocytes by immunohistochemistry, so it has other features of malignancy, so this is a malignant tumor deriving from melanocytes, so this is a melanoma, and which is the most important prognosticator. It is the Breslow thickness. That's why we've drawn this line here. This is the upper part of the tumor. That means, you see the cells here, the malignant cells, the upper part, and this is the lower part. This is the thickness, the maximum thickness of the malignant melanoma, and this is Breslow thickness, and it should be counted and always reported in our pathology reports, because the millimeters of invasion define the patient's survival. If it is less than 1 millimeter, the patient's survival is very high, 95%. If it is Breslow thickness is 2 to 3 millimeters, then it drops. The percentage of survivors drops to about 85%, and as more as it grows, it increases the Breslow thickness, the patient's survival decreases. The Breslow thickness, you count the Breslow thickness. You count the millimeters from here, Breslow. But you have done lessons on the skin. Didn't they tell you of that? Did they tell you that the Breslow thickness in melanoma, it wasn't that important? The most important factor of survival in patients of melanoma, wasn't that properly stressed in the lesson? Oh no, I have to do all the theory as well. No. Well, it will happen in the next term, unfortunately. And you will see me every week here and say, not him, no, not him again. No, no, it's unbearable. Yes, please. The markers, the immunomarkers, it's melan-A antibody, or MART1, HMB45, and SOX10, I think. Check it up for me, please. SOX10. Okay, this was the malignant melanoma. And another annotation here. Ah, that's a nice annotation. What has happened here? And is compatible with malignancy. What has happened here? What is within the tumor? What do we see? This is not the ulceration in the surface. This is melanin. Yeah, it is. And it is quite finely granular. You see the melanin? This could be a sign of melanocytic. Yes, but this material here, you see, there are some shadows of the pre-existing nuclei. So what is this area that we find within the neoplastic population that is compatible with its malignancy? Yes, please, tell me. You please. I can see you. You keep noting. Yes, you. Yep. Tell me. Yep. It's necrosis. Yes, this is necrotic activity. And as we said in the general principles of neoplasia, if we have necrotic activity within a neoplasm, this is a sign favoring malignancy. So this is a necrotic area. Small one, but it's necrotic. What type of necrosis is this? This is coagulative necrosis because it results from ischemia. The malignant melanocytes have such increased potential to grow that neovascularization is not enough. It's not enough, so they become necrotic. Okay. And is there another useful annotation? What? That's yeah, you see here? These are melanocytes. Are they viable melanocytes? No. This is an area of necrosis as well. Why? What are these? These are the shadows of the pre-existing malignant melanocytes that have now become necrotic. So those were the skin nodules. Now, as I see, now we have 1 hour of lesson. So we'll finish at 12 o'clock. Only the slides that I'll manage to show will be in the exam. So I'd better hurry and show you as many slides as I can so that you will have many slides to study. Because if I start in each slide and say, this is the dermis, this is the epidermis, this is the mitosis, this is the necrosis, then we'll just have an exam on skin neoplasms, not in other parts. So I'd better hurry now and tell them, nobody understands anything, that's okay. Like the TikTok videos you like so much. I cannot make. I have the YouTube channel. I make longer videos because I cannot make them in 1 minute. No, I cannot do that. Sorry. There is another colleague that makes the TikTok videos. Konstantinos Hadjidimitriadis. He's a resident here. He makes TikTok. Have a look. Check him out. Have a look on that. He's very good at this. So, now next one. You'll choose either endocrine or lymph nodes. You tell me, who wants to have the endocrine? The endocrine, everybody wants the endocrine. Yeah, okay, we'll do the endocrine now, but then I'll do the lymphomas, okay? We'll have the endocrine pathology now. Okay. I think that we have already discussed it. I think that we did a lesson, a lab exercise on the endocrine pathologies, but we'll repeat it now. The first one is very, very simple. Everybody who gets this slide in the exam, then he'll go and have a joker. He'll play the pools. What is this? This is a case of an increase in the size of the thyroid because we have goiter. And we have euthyroidism. That means the hormones are normal of the thyroid, T3 and T4, because all we have is a not homogeneous reaction of parts of the thyroid to the stimulation of TSH. So some parts of the thyroid grow in nodules. So where are the nodules? We define the nodules by their contour. And we have this configuration. This is a nodule. This is a nodule. This is a nodule. And in this nodule, we see that the follicles are of different sizes. This is a cystically dilated one, where the follicular epithelial lining is flattened. And these are smaller follicles that we can easily see the lining of the epithelial follicular cells. So these are the nodules of nodular hyperplasia of the thyroid, and if it lasts long, we have fibrous tissue development. This is an area of fibrosis, you can see, And always, especially when we have some signs of calcification in these areas, we always have to cut deeper sections because sometimes we might find a papillary microcarcinoma in areas of fibrous replacement of the gland. But this is not a rule. So this is the easy slide. We have nodular hyperplasia of the thyroid. The next one is an autoimmune lesion, inflammatory lesion, and the cause of primary hypothyroidism. That means that the patient feels tired, he has gained weight. So the levels of T3 and T4 are low. However, being a primary lesion of the thyroid, what are the expected levels of TSH? They will be very high because the problem is in the thyroid itself. So this is Hashimoto's thyroiditis, and we have a dense lymphocytic population within the thyroid parenchyma. And you can see here that some lymphocytes are of B origin because what do they form? What is this? This is a lymphoid. Have a look. This one, this one, this one. Of course, there is a population of B cells within the dense lymphocytic infiltrate of the thyroid because we can see what are these structures that we know that there are B cells here. What are these? They are lymphoid follicles with active blast centers. So since this is an autoimmune disease, these B cells will secrete autoantibodies that will circulate, and when we count them in the blood, this will be compatible. It's not absolutely necessary for the diagnosis, but of course it's compatible. The presence of autoantibodies against thyroglobulin. The other cells are probably of which nature, so that the destruction of the follicles, you see how they become shrinked, how the follicles become shrinked. So what other cells are expected to be here? What other cells are expected to be here so that they attack? Because this is an autoimmune disorder. That means the immune populations of the host attack some structures of the host himself. So what cells do you expect to be here? These, I cannot tell that they are B cells because they do not form lymphoid follicles. They could be B cells, but what other cells could they be? So that we justify the destruction of the follicles. That means they will attack the follicles. They will be cytotoxic cells. So which cells are they likely to be? Yep. Excellent. We have T8 lymphocytes and another subpopulation of lymphocytes attacking cells. Which ones are they? Excellent. The natural killer cells. Very good. I have to congratulate the teacher that did the exercise, the laboratory exercise on endocrine glands. He's done a great job. I'll keep him in the lesson. I'll keep him. Yeah. No, I'm not a narcissist. It was a joke. No. Don't get me wrong. No. No narcissism in medicine. It hurts. It's too harmful for the patients. No. So, this is the lymphocytic. All right? The dense lymphocytic infiltrate replacing the thyroid parenchyma. All right. Next, have a look at the cells lining these follicles. No, not these ones. Let's check. These ones. Yes, I like them. You see? These are the cells lining the follicles. Have a close look at these normal appearing follicular cells and in contrast to these ones. What are these cells now? What's the difference between these cells and the ones I previously showed you? What's the difference? Again, let's try again. Have a look. Yeah, at these cells, normal looking, and have a look at this one. You see? This one. Let me find them another place. And they want them to be typical. Oh, yeah, these ones. You see? You see the cytoplasm has grown big, and it's too pink because there are too many mitochondria gathered. They have gathered in the cytoplasm. And these cells are called, remember, oncocytes or Hirfle cells. So this is some sort of metaplasia from the follicular cells. They have become oncocytes, Hirfle cells. This is oxyphilic metaplasia. And this is a hallmark of Hashimoto's thyroiditis. And as time passes and the thyroid parenchyma becomes atrophic, what tissue do you expect to replace the thyroid parenchyma in the chronic phase of thyroiditis? Which tissue do you expect to become the major component of the thyroid? Scar tissue, yes, fiber tissue. Here it is. Here is scar tissue. You see? Acellular. This is just collagen, acellular tissue. Scar tissue is going to replace the whole thyroid gland in the advanced stage. All right. Another slide. Let me see. What is this? Yes, this is the oxyphilic metaplasia. All right. And here we have the fibrosis. Okay. You see now the lymphocytes are not predominant like in the previous case. That means we have scar tissue, we have chronicity. Very good. Now, let's check now the commonest malignant neoplasm of the thyroid, which is often incidentally diagnosed either from its rise in the thyroid or from its regional lymph nodal metastasis in nearby, which however does not worsen survival. If we have, this is papillary thyroid carcinoma, despite its regional metastasis, it does not make the prognosis poor. So here is normal thyroid parenchyma. These are normal follicles with totally normal nuclei, and this is the lesion. Here it forms all these papillae, which are true papillae. And why do I call them true papillae? Because of their fibrovascular stalks. The fibrovascular stalks. You see? This is the capillary and this is the connective tissue. So these are true stalks, true papillae. So this is the architectural pattern of classic papillary carcinoma. Under condition that I can always define nuclear features of malignancy. What are the nuclear features? We have overlapping nuclei. Here they are. You see how they coalesce, how they overlap each other, how they aggregate, and they are empty. Because this is a sign in tissue sections. So have a close look, because we have empty appearing, overlapping, crowded nuclei. Of course, they may be increased in size by comparisons to the one that we have previously seen in the adjacent normal parenchyma, and they also have some grooving. Here it is. You see the grooving? This one, and that one. And we should also look for pseudonuclear inclusions. That means some like small balls within the nuclei. Can we see those? I'm not sure that we can see them if I have not. Oh no, I think I saw one. Well, here it is. Oh, where was it? I missed it. Oh, no, I dreamt of seeing one, sorry. Oh, yes, I saw one. Here it is. Oh. What is this? This is a cytoplasmic projection in the nucleus. This is a nuclear pseudo inclusion. Very typical. You see, this is the nucleus. You see, this is the nucleus, and this is the inclusion. The nucleus and the inclusion. Great. Another one. This one. Look, there are too many. I do not believe that. Here they are. You see? Good. Now, what else can we see here? Now, one part of the papillary carcinoma has this architectural pattern. Which structures do you recognize here? Are they papillae, like the previous? Are they finger-like? No. What are they? What are these structures from a histological point of view? What are they? They have lumen, so they are follicles. Pay attention. This is not follicular carcinoma. No. This is a follicular pattern of papillary carcinoma. So, despite the fact that we see papillae or follicles, we should always check the nuclear features. These are the ones that define the papillary thyroid carcinoma. It can have papillae, so it's classic, of classic type, but it can also have follicles. The diagnosis is papillary carcinoma as long as we can see the nuclear features. So these are the ones that make the diagnosis. And look here, the characteristic overlapping of the nuclei, of the empty nuclei, known in the literature as, how did we find them when we did the laboratory exercise? How did we call them? Due to the Orphan Annie cartoon character with the empty eyes, and also the empty eyes referred to what other than Orphan Annie. Orphan Annie is the character, and she had empty eyes like this, but also the same applied to her. Excellent. Excellent. Her dog had empty eyes too. Like Orphan Annie. The dog had one. The dog had empty. Well, the summer, I think the summer is good for me. Yeah, I think the summer, yes. Okay. Provided that it's not too hot. No, not too hot. Like today. Okay, like today. I like the summer like today. Okay. That was the papillary carcinoma, and we would always check. Ah, look here. Oh no, what happened here? We see some parts of the papillary carcinoma invading beyond the capsule of the thyroid. So this is extracapsular invasion, and it is important to be reported. And we should also check the margin, either of the thyroid capsule or the surgical margin of soft tissues. What sort of soft tissue is this? This is skeletal muscle of the region. It's tumor-free. However, I think that this papillary carcinoma grows beyond the thyroid gland in the perithyroidal adipose tissue. Okay. Next. Here is another papillary carcinoma. I think we are okay. Now, this one. Here we have a single nodule. So, when is a single nodule suspicious for cancer? It has to be solid, not cystic, single, and cold in the scintigram. That means that its cells will not uptake the iodine because they do not function as normal follicular cells because they are malignant cells. So this is a sign just favoring malignancy if we have a cold nodule. It's not necessarily a sign of malignancy. However, we should check him, and we have an FNA, a fine needle aspiration biopsy, to check a single nodules, because when we have many nodules, like the first slide we saw in the endocrine gland pathology, the nodular hyperplasia, when we have many nodules, the possibility of cancer is minimal. The possibility raises when we have a single nodule, And let's have a look at the cells. Do they look like the nuclei of papillary carcinoma? No, they are not empty. They have no grooves. They have no nuclear pseudo-inclusions. They are not big nuclei. But what do they form? What structures do they form? Follicles. They form follicles. So this is a follicular lesion. So what could this be? Being single. Because if there were many such lesions, this would be nodular hyperplasia, multinodular goiter. Now we have one. We have one nodule, so we have to check. What is this? So it could be a follicular cell neoplasm, that means a follicular adenoma or a follicular carcinoma, or just an adenomatoid mimicking adenoma, an adenomatoid nodule. And that's the case here because it has no true capsule. That means that it is not totally encapsulated by a thick capsule that would mean that it could be defined as a follicular adenoma or carcinoma if the capsule was invaded. So, if we have just a single nodule in the thyroid being composed of microfollicles or bigger follicles with no signs of nuclear features of papillary carcinoma, it's of vital importance to exclude a diagnosis of papillary carcinomas and of papillary carcinoma. And we do not see a true capsule. This is an adenomatoid nodule. If we see a full capsule throughout the tumor, like here, and you see the capsule all around and quite evident. This one, this is the capsule, all right? This is just an area of hemorrhage. Now, we have a single lesion which has a fully developed thick capsule throughout the tumor, all around the tumor. And sometimes, always, there is fibrous tissue in the tumor. This is compatible with prius FNA, because if we put the needle and we take the needle out and take cells and have the cytological specimen, then fibrous tissue may develop. Pay attention not to think this is invasion. You have to know the history that an FNA was performed in the patient before surgery. And this pattern of microfolliculars, you see how tiny. They are too tiny. The follicles are too tiny, so we cannot see there. Cannot see there. If they are too tiny, we cannot see their lumen. Okay? So this is a follicular pattern. This is a single nodule, fully encapsulated throughout its contour, and of course it looks different than the normal adjacent tumor adjacent parenchyma. It's different. Okay. And oh, I forgot the most important. There are no signs of papillary cell carcinoma nuclei. Always check. No, they do not resemble the empty orphan Annie nuclei. So this could be defined as a follicular adenoma. And to be more exact, microfollicular, because its follicles are too small, microfolliculars. And so perhaps this nodule could be hot in the scintigram, because sometimes it overfunctions and it is a cause of hyperthyroidism. This would be a hot nodule. Not always. It's not always. A follicular adenoma can be cold. A cold can present as a cold nodule, but it can also present as a hot nodule. The same may happen in the background of nodular hyperplasia when one nodule becomes overproduces thyroid hormones, and this makes him a dependent nodule. But this is not the case. When we have hyperthyroidism, then we have Graves' disease. This is the most common case of primary hyperthyroidism. And I say primary, that meaning that the TSH hormone will be low because the thyroid hormones will be high, and the patient will be always anxious. He will have heart beats, and the heart will work more quickly, and he will shake a bit, something like me, to get it. But I'm okay. I've checked, and no, there is no hyperthyroidism in me. And he would lose weight. I do not lose weight easily, so it's not my case. Okay? Yes, please.
So if you see the capsule throughout, that's more consistent with the follicular.
Of follicular neoplasm, not an adenomatoid nodule like the previous. We have a follicular neoplasm, either benign, that's a follicular adenoma, or malignant, a follicular carcinoma. So in the follicular adenoma, there will be no signs of invasion. It will just stay within the capsule, the neoplastic population. By contrast, we see the next one.
Sir,
Yes, please.
can you repeat the name of the blood stain for the cold and cold differentiation?
The stain which?
You said the name before for the cold and cold differentiation.
So if it's cold, that means that we have a scintigram and does not uptake.
Skinky.
The scintigram. That means a scintigram. Yes, yes. That's the exam that you give. No, that's the exam. You give the radioisotope. It's not the same like the one you treat follicular differentiation cancer. Not the same. It's another radioactive. I don't. Yes, I'm not sure what they give for the scintigram and what they give for therapy. I do not know that. I know a lot, but not everything. Okay, I know a lot. Okay, it's okay. Not everything. I don't know. I know it's different. The one, if the nodule takes it, it's hot. If it doesn't take it, it's cold, and it's more likely for it to be malignant. More likely. It's not necessary. Oh, we are the ones to judge the malignancy, not the radiologists and the nuclear. They don't know. We only know. The pathologists know everything. So this one now. So why is this a follicular thyroid carcinoma? First of all, it lacks nuclear features of papillary carcinoma. Then, we have some evidence of invasion. However, this is not the case here, because this is fibrous tissue which developed within the neoplasms parenchyma due to a prior fine needle aspiration. So we have to know and not misjudge this area as invasion, because we see neoplastic cells around the fibrous area. This is not true invasion, because something has happened to the patients, and we should always know. That's why the clinician must be in cooperation with the pathology and tell him all the clinical information so that the pathologist makes the diagnosis properly. However, in this area, we have some vessels and we see some epithelial cells within the vessels, so this is suspicious for vascular invasion. And if we find intralumen emboli, cancerous neoplastic emboli, this is a hallmark of malignancy. So, how will we define this as a follicular cell carcinoma, which is a different kind of cancer than papillary cell carcinoma, more aggressive, because papillary carcinoma gives lymph node metastasis and mainly regional lymph node metastasis. On the contrary, follicular carcinoma may be well differentiated. That means it derives from follicular cells and it looks so. Both papillary cell carcinoma and follicular cell carcinoma express thyroglobulin immunohistochemically because they are well differentiated tumors and their cells are immunopositive for thyroglobulin because they are well differentiated cancers of thyroid follicle epithelial origin. However, this one gives hematogenous metastasis. It spreads in another way, so it is of crucial importance to diagnose this low-grade cancer, this well-differentiated follicular cancer, as follicular carcinoma and not papillary carcinoma. And here we might have a population of follicular cells within which part? Because this being a follicular neoplasm, it should have a thick capsule, like the adenoma. However, we see cells within this thick capsule, so this might raise suspicion of invasion. So, how is follicular carcinoma diagnosed? It's diagnosed by the lack of nuclear features of papillary carcinoma and the invasion either of the capsule, either of its capsule, within its capsule, or outside beyond the capsule, or by invasion of vessels, blood vessels, either within the capsule or beyond the capsule. So when we see this invasion from a tumor, in a tumor with follicular differentiation, here are the follicles, no signs of nuclei of papillary carcinoma, so this is follicular cancer. Which are the two types of well-differentiated thyroid carcinomas? Papillary carcinoma and follicular carcinoma. They both have signs of differentiation from the follicular epithelial cells, and they both express thyroglobulin immunohistochemically. This tumor may not express thyroglobulin, however, it expresses immunohistochemically another marker of thyroid follicular cell differentiation known as TTF1. So, now the grade has increased. This is no longer well-differentiated tumor, a well-differentiated tumor. It is a poorly differentiated tumor of follicular cell derivation. That's why TTF1 is expressed, and thyroglobulin may be expressed, but it is diminished, its expression is diminished, and compatible with the high grade of differentiation is this pattern of development of the neoplastic cell population. How would you describe this pattern? Do you see papillae? No. Do you see follicles? No. How would you describe this pattern of differentiation? Oh, and there are many mitoses. Look, 1, 2, If you count, I think I told you when we had the labs, they should be more than 3. But I'm not sure, is it within 1 high power field or within 10 high power field? I think we count 10 high power fields in poorly differentiated thyroid carcinoma. You look at your notes and tell me, okay? But it is of increased mitotic activity, being of high grade, being of poor differentiation. And what pattern is this? How would you describe this pattern that predominates in this neoplastic, malignant neoplastic population? If you see just sheets of cells, it is a solid pattern. Solid pattern. This is compatible with high grade, poor differentiation. We see mitosis here. I made that sign, I remember. Yeah, you see in one such small area, 3 mitoses. So yes, it exceeds the number of mitoses you should count in 10 higher power fields. You just see it in 1. So that's a poorly differentiated carcinoma. However, in some places, I think you can see a pattern that reminds you of something that we've already seen. Despite the predominant solid component of the follicular cell carcinoma, what pattern is this here? Which is just a minority, but what do you do? Follicle, it has a follicular pattern as well, okay? And of course, we have no signs of the nuclear features of papillary carcinoma. So that was the poorly differentiated thyroid carcinoma. And let's have a look here. Yeah, we have a follicular pattern of the carcinoma as well in this area. Okay. Next one. The next one is the most aggressive cancer of thyroid, and possibly one of the most aggressive of the whole body, is anaplastic carcinoma. That means it is a morphologically undifferentiated carcinoma that derived from follicular epithelial cells, cells lining the follicles. However, it does not express thyroglobulin at all. It does not express TTF1 at all, so there are no immunohistochemical signs of follicular differentiation. So we must at least say that it is a carcinoma. Why do I say that? I say it because in some areas, in these areas, you see the cells are somehow spindle in nature. So how can you be sure that this is a carcinoma? If you see a spindle cell component in a tumor, in a malignant tumor, what might you suspect? Of which tissue might you suspect that it comes from? If you see malignant spindle cells, what would you think? The carcinoma is not the first malignant tumor that you think of. If you see a spindle cell population, which tumor would you think that it is if you see just this area? Because I see some sort of fascicles and spindle cells. What does it appear like here? What does it appear like? Yes, please. Deriving from connective tissue. And how do we call malignant mesenchymal tumors? Tumors deriving from connective tissue, from muscle tissue, from neural tissue. How do we call them? Not carcinomas. No. This is benign. You have to tell me the malignant one. How do we call it? Who did the mesenchymal tumors? Oh, I won't. He won't do the next year. And he'll be very sorry, I'm sure he'll be very sorry for that. Whoops. Yep. If it comes from fibrous tissue, yeah, fibrous. It's a sarcoma, a malignant tumor of mesenchymal origin, of mesenchymal tissue. For example, from skeletal muscle, rhabdomyosarcoma, from smooth muscle, lymosarcoma, from fibrous tissue, fibrosarcoma, from neural tissue, neurosarcoma, all this. Okay. So it doesn't help me at all. This area here, can you define what has happened in this highly malignant, morphologically undifferentiated tumor? It's necrotic. A large amount of the tumor has become necrotic. due to its increased aggressiveness, biological aggressiveness. Have a look at this sign. What is the hallmark of high grade in here? What is the hallmark of high grade morphology? The nuclear pleomorphism. Look at the sizes and the shapes of the nuclei. This is a very increased degree of pleomorphism. And next, what is to be expected, of course, is, what are these? Increased mitotic activity. So this is a highly malignant, undifferentiated, morphologically undifferentiated tumor. No signs of no follicles, no signs of epithelial differentiated, not just follicular. No signs of epithelial differentiation. So what is necessary to define the epithelial origin of this tumor? What is necessary to do? Morphology does not help us. It is undifferentiated morphologically. So we have to perform immunohistochemistry. And hopefully, some degree of a panepithelial immunomarker will stain some parts, at least, hopefully, some parts of this tumor. And which is the immunohistochemical marker of epithelial differentiation in general, that all epithelial tumors should express, at least at some parts of their parenchyma. Which one is it? Yes? This is what appears in the microscope, in the electronic microscope. It is not easy. The tumor sometimes may be so undifferentiated that we have to look in the electronic microscope to define its derivation. But that is very rare to have electron microscopy for the definition of a tumor, which is the marker that stains all epithelial-derived tumors. Which is the marker? A panepithelial marker by immunohistochemistry. Yes, it's cytokeratin, not the one you see in squamous cell carcinoma, in hematoxylin eosin sections. This is a morphologic feature. No, you have a pancytokeratin antibody against pancytokeratin. You stain the malignant tumor with immunohistochemistry, and so you say, it's from epithelial origin, so this is an undifferentiated thyroid carcinoma, or an anaplastic carcinoma with a very ominous prognosis.
So vimentin works too, right?
It might confuse us, because vimentin is a non-specific marker, but mainly for sarcomas, not carcinomas. However, I would not be surprised if such an undifferentiated carcinoma would express vimentin. There are some carcinomas that express vimentin, such as renal cell carcinoma and endometrial carcinoma. But generally, vimentin is a marker of sarcomas. Not a very good one. Next one. Now, we have a tumor in the thyroid that does not derive from follicular cells. It appears to have a rather organoid pattern composed by homogeneous looking cells, at least as the shapes and sizes of their nuclei are concerned. In general, when we see a pattern of homogeneity in the morphology of a tumor, this could be taken as a sign of a benign tumor. Yes, I know. However, there are some potentially malignant tumors that also have homogeneous appearing cells. Which differentiation are these which is the differentiation of these tumors that have malignant potential and their cells generally look like each other? Which ones? Which one are these tumors that they have neoplastic cells that look like each other? which markers of immunohistochemistry will help us define this differentiation? Which? Know that? When we have a tumor with homogeneous cells, we must look for neuroendocrine differentiation, because neuroendocrine tumors have mainly homogeneous cells when they are of low grade, previously known as carcinoids. So, which are the immunohistochemical markers of neuroendocrine differentiation, which are expected to be expressed in this thyroid tumor, which does not derive from follicular cells, so it will not express thyroglobulin, it will not express thyroglobulin by immunohistochemistry, but it will express neuroendocrine immunomarkers as well as calcitonin, because this tumor derives from C cells which produce calcitonin, and they belong to the neuroendocrine population. These markers are, apart from calcitonin, which in the present case should be positive, which are the markers of neuroendocrine differentiation? Remember? Excellent. Synaptophysin and chromogranin. So this will be positive and will help us define this tumor as a myeloid carcinoma. You see the cells? They somehow have that salt and pepper pattern of chromatin distribution. You see here in the nucleus the salt and pepper. This is consistent with low-grade neuroendocrine tumors. However, this tumor, I'm not sure it is of low grade because it has an aggressive behavior. It can metastasize hematogenously to the lungs. Another helpful diagnostic feature is this deposition of this substance, which appears somehow amorphous in hematoxylin eosin stain sections. However, it is quite red in the Congo red. What are these? More slides for us? This, you'll give that to Dr. Agrogiannis. Have you scanned them?
Yes.
We'll put them in the male genital pathology.
Okay.
Okay, give them to George. Okay, thank you very much. So what substance is this that stains red with Congo red stain, and it has, under polarized light, it has this birefringence. It's about it becomes yellow, green, yellow. Yes, what is this? Amyloid. And this specific amyloid has a homology in its amino acids to the molecules of calcitonin, because the cells that produce calcitonin are the cells making the term is medullary. The term is medullary carcinoma of the thyroid. I think I got it wrong. Medullary carcinoma, not myeloid, medullary carcinoma. All right? I'm sure you've heard that in the theory lesson. Okay? Have you heard it in your theory class, the medullary carcinoma? I hope so, because I think you have learned nothing in the theory class. I'm not sure. Anything I ask, everybody listens for the first time. That's why I don't like theory classes, in any case. Because, as I told you, you do not learn from textbooks. Medicine is not learned from textbooks and from studying. You learn it from practical issues. You learn the practice first, you'll become clinicians. You have to know how the lab will help you to diagnose your patients correctly and have their prognosis and their treatment. So, this is a practical procedure. This does not appear in textbooks. No, it doesn't appear in textbooks. It appears here in practice. You learn the practice, you understand my job. What do I do here? Macroscopic detection, microscopic exam, what I report, and you get this knowledge, and understand its usefulness for your patient, for your job as a clinician. This is not learned in textbooks. You get the practical grip of medicine, and of course, you are not a technician only. You are a technician, but not only a technician. You are a scientist. So then you study. Then you study the textbook and theory, because you have to deepen your knowledge, not just learn practical tips for your job. But what you start is the practical part, not the theoretical part, because you won't understand anything in the theoretical part that is not connected to your everyday job as a patient. That's the whole part, that's the whole theory in medical education, and as far as I'm concerned, in any sort of education. You do not start from theory. It's wrong. It may be easier. I agree, yes. It may be easier for the professor to just stand there and read some slides. Yeah, okay. That's another issue. Okay, so this is amyloid deposition, which will help us make the diagnosis of medullary carcinoma. Yes. And then we have this sort of parathyroid lesion, which consists mainly of chief cells, and they predominate here. There are no fat cells, which should be discernible in the thyroid tissue. This is a monomorph population of chief cells that overproduce parathormone. They overproduce parathormone, and what does this cause to the patient? If it is a lesion of more than one gland, this is hyperplasia. If it is a lesion of one gland, there is a possibility that it is a parathyroid adenoma, but it should have a rim, and you'll see the normal part of the parathyroid, which will have not just one cell population, it will also contain some fat cells and oxyphilic cells, and then you'll have the adenoma that consists mainly of chief cells as this one. But this is probably hyperplasia of parathyroid. So, what will happen? If there is hyperproduction of parathormone, there will be increased calcium in the serum, so the kidney might be affected and stones may be formed. And the patient, when the stone moves, it causes muscle spasm in the place of the part that it moves, so he will have colicky pain. So there is no use treating the stones. You'll have to treat the cause of increased calcium and increased parathormone. So you have to check the parathyroid glands if they have hyperplasia, as is the case in this slide, or an adenoma, or very rarely a carcinoma, which causes very, very severe hypercalcemia. But if the parathyroid glands are normal, then you have to check secondary hyperparathyroidism. That means if there is a kidney disease that is responsible for the hyperplasia of the parathyroid. This is the case in uremic patients with renal insufficiency. But if the parathyroids, in any case, either of primary or secondary or tertiary hyperparathyroidism is excluded, then what will you look for? If the parathyroid hormone is excreted from another source. This is called ectopic production of the hormone, not from the gland, not from the lesion, not from the endocrine gland that is supposed to secrete it. And which are the frequent sources of ectopic production of hormones? And in the present case, of something mimicking the role of parathormone, which is the case here. Where should you look? Where should you look? To get the source of ectopic production of a hormone. Yes? Yep.
I was going to say neuroendocrine tumor.
It could be a neuroendocrine tumor and justify this. Yes. Correct. And a malignant tumor. A cancer can do that. And these are called paraneoplastic syndromes. That means there is some place irrelevant to the parathyroids. For the lung, there is a cancer in the lung, and it overproduces a substance that acts like parathormone and causes hypercalcemia. However, this is not an orthotopic production because it is not produced by the parathyroid cells. It's produced from malignant cells. Yes. So that is parathyroid hyperplasia, which causes hypercalcemia. So that's the end of the slides from the parathyroid. We won't study today the adrenal gland adenoma and the pituitary gland adenoma. And now we'll have the lymph node slides. Have a look at this lymph node. What is there for us to see? We have to see if we can understand the basic structure of the lymph node. That means we have the capsule. Yeah, here is the capsule. And here is the subcapsular area where lymph comes to the node. And here we have the B zone. And what are these structures of the B zone? You see here. Yep. The lymphoid follicles. And when they are activated, they are secondary. You see that the cells within the lymph follicles are not monotonous. There are many types of cells in an activated lymphoid follicles. And what other mechanism is functioning? Have a look at these cells. What has it phagocytosed? What are these small fragments here? Because if we have a hyperplastic lymphoid follicles, that means that there is activation of the lymphoid tissue, and cells may proliferate more, but they can also do what? Have a look at this cell, this one. What has it phagocytosed? It is an apoptotic body. That means in a reactive lymphoid follicles, we'll see a heterogeneous population within the blast center, and there should be some signs of apoptotic activity. How do we define apoptotic activity? We find some macrophage phagocytosing the apoptotic remnants. So these are normal follicles. All right. Then we look at the T zone. Which is the T zone? The T zone is the one between one follicle, lymphoid follicle, and the other. This is the place where we have the T cells. So, what do we see here? In this part of the node, we see the lymph follicles, this one, and other lymphoid follicles, and we see that this area, the parafollicular area, the T zone of the lymph node, is somehow expanded. It is not a main distortion of the lymph node architecture, because we can understand where the B zone is and where the T zone is. However, if we look closer, here there are some cells like these. You see these cells, which are some cells of inflammation that have gathered here because and caused the expansion of the parafollicular zone. So, what are these cells? And let's have a look, what do they phagocytose? Because in some places, we might see pigment similar to the one that we saw in the melanophase, the one that we saw in the melanocytic lesions that we have studied. So these are macrophages. The expansion of the T-zone is due to macrophage accumulation. So how could pigment reach the lymph node? Perhaps you have an itchy skin lesion, and as you scratch the lesion, melanin comes in the dermis. The macrophages take the melanin. Remember how coarse the melanin pigment, coarse granules appeared in the cytoplasm of macrophages. Then macrophages enter the circulation, go to the regional lymph nodes, and they expand the T-zone. This is not a sign of malignancy, because these are not malignant cells. There is a distortion in the architecture. However, it is not such a severe distortion that would justify the diagnosis of a lymphoma. And of course, if you have the immunomarkers, the B cells will be as they should be, the immunomarkers of B cells. Which are the immunomarkers of B cells? You should know the basic ones, CD19 and CD20. And which is the pan T cell marker? A marker for T cells, it's CD3 for all T cells. And if you see the distribution of the immunopositivity, it will be like the normal lymph node. So there is some distortion in the architecture, but not severe enough to justify the diagnosis of a lymphoma. I expected to be able to find the pigment in the melanophase, the melanin pigment, which might raise suspicions, of course, of a melanoma metastasis, which is not the case, because these are not melanocytes. They are not positive to markers of melanoma cells, as we said, SOX10, HMP45, MART1 melan-A. These are macrophages. So they would express CD56, for example. However, I'm not sure that I can see the melanin. I showed you the macrophages in any case. So if the history is compatible, this is a dermatopathic lymphadenopathy, which is a reactive lesion. When lymph nodes become enlarged, they are most commonly enlarged by reactive lesions, not neoplastic. All right? This is the common type. And from this case, I'd like you to see how many the lymph follicles are. I can see the mantle zone easily after the blast center. And I want you to keep in mind that in the activated secondary lymphoid follicles, there is a heterogeneity in the morphology of the activated B cells. They are not monotonous in appearance. Have this in mind. So this is the slide of a reactive lymphadenopathy. Now, we have now this lymph node, possibly from the mediastinum. What's the easily discernible abnormal feature in this lymph node? What is there? You see that it is not compatible with normal lymph node architecture and morphology. This is something strange. It could be a capsule, of course, because it's connective tissue, but it is not. It comes within the node, so it is no longer a capsule. It's some sort of a septum, a diaphragm that divides different parts of the lymph nodes and gives the lymph node what configuration? Look, here is the septum, the fibrous septum. Here is what it makes. You look at the septum. It comes this way, comes this way, comes this way, and it forms. How would you describe this area of the lymph node as the shape it takes from the septum that surrounds it? How would you describe that? What do you think? If it comes all these ball-like structures, these are nodules. These are nodules. And the whole lymph node has some nodular structures due to the sclerotic tissue, the sclerotic fibrous tissue that is developed. So let's go within one of these nodules and see if they are normal lymphoid follicles as the one we previously saw. Of course not. What is the hallmark of malignancy in this cell population within these nodules? How can you tell that these cells are malignant? How? What is the most evident sign that these cells are malignant? And they have nothing to do with the activated cells in the blastic centers. What is the hallmark of malignancy here? Yes, please. Yeah. Pleomorphism. The nuclei are highly pleomorphic. So these are some neoplastic giant cells. Let's have a closer look at them. We'll find them throughout the nodules in the lymph node, throughout the nodules, and we'll have a look at them in many places. They are everywhere in the lymph node. You can see them. Yes. Shall we try here? Yep. Everywhere. Everywhere you look, you find such cells. So, some of them are dividing. It's logical because these are the neoplastic cells of the lymphoma we are studying now, so it's logical that they have increased mitotic activity. Yes. Some of them have one nucleus with a highly prominent nucleoli. Some others have two nuclei. This is a giant cell with one nucleus. Have a look at how prominent and eosinophilic the nucleoli appears. And there are others that appear to have two nuclei. The ones with the, here, you see, it is mitotic, because these are the malignant cells. So when we see such cells, the ones that have two nuclei are the Reed-Sternberg cells. And the ones that have one nucleus, they are the Hodgkin cells. And in this subtype of classic Hodgkin's lymphoma, the cytoplasm is vacuolated, so these giant cells are known as lacunar cells. However, despite the distortion of the architecture nearly of all the lymph node and the presence of such cells, it is mandatory that we defined the neoplastic giant cells of Hodgkin's lymphoma by immunohistochemistry. It's mandatory. And which are the two markers that all subtypes of classic Hodgkin lymphoma should express. Which are the two markers that all subtypes of classic, now we are talking of classic Hodgkin's lymphoma. What are they? Yes, please. I'm not this one. Has this something to do with plasmacytes? Check it up. Check it up. The MAM one. It's CD15 and CD30. All right? And despite that it is a lymphoma, CD45, which is the common leukocyte antigen, is paradoxically negative. So, how do we diagnose classic, I stress this, classic Hodgkin lymphoma? Because we have another type of lymphoma that derives from B cells, so it expresses B cell markers and CD45. But this is not classic Hodgkin lymphoma, as the one we are studying here, the nodular sclerosis subtype, which is, I think, the commonest subtype of classic lymphoma. By the way, as I'm sure that you have studied theory thoroughly, how is the non-classic Hodgkin lymphoma type called? The one that expresses B-cell markers. How is it called? The one that expresses B-cell markers and CD45. This is, yes? Yes, this is the nodular lymphocytic. How is it called in English? I'm not sure. Nodular lymphocytic, how is it called? Not the classic lymphoma, Hodgkin lymphoma. The classic Hodgkin lymphoma has mixed cellularity, lymphocytic predominance, lymphopenic, and this one, nodular sclerosis. These are the 4 subtypes of classic Hodgkin lymphoma. We see the commonest. The nodular sclerosis, we saw bands of sclerotic tissue and nodules which contained the neoplastic giant cells, either binucleared, Ryd-Sternberg cells, or mononuclear, Hodgkin cells and lacunar cells, meaning they have empty cytoplasm that's due to fixation with alcohol. And there is mitotic activity logically in these cells because this is the neoplastic cell component of Hodgkin lymphoma. However, in some areas, apart from the neoplastic giant cells of classic lymphoma, being CD45 paradoxically negative, CD15 positive, and CD30 positive, we see some other cells that I am sure you are able to identify because you had obtained excellent grades in the first practical exam that we had the inflammation and the inflammatory cells. So now that your knowledge is deep enough because you had the practical exam and understood what you saw, not just what the multiple choice question from the test said. Anyway, so what are these cells? I'm sure you identify, because if you don't understand, identify, I'll have to, how is it called, to annual, to have the practical exam grade, I will not take them into account and do in next Tuesday both exams. The first one, the first 3 laboratory, and the rest 5. We'll have all the exams. So please tell me, what are these cells here? I'm sure you know them. Have a look. Of course, thank God. Of course, these are eosinophils. They have lobulated nuclei. Have a look at the nuclei. Look. You see they are lobulated? Ah, okay. And this one. However, they are not neutrophils. Why? Because the cytoplasm is too red to be neutrophils. So these are eosinophils. So what are they doing there? What are they doing there? The eosinophils among the lacunar giant cells. What are they doing there? Look, a very nice one. What is this one? Another cell. This could be a neutrophil. So we see eosinophils, we see this could be, this has a lobulated nucleus, yes. But I see, here is a plasmacyte. But what are they doing there? Why? Oh, how many nuclei does this giant cell have? This one has 3. So I'm the first one who noticed that some giant cells have 3 nuclei because Ryd-Sternberg cells have 2 nuclei. Hodgkin cells have 1 nuclei. So since I am the first one who noticed that some cells have 3 nuclei, how do you think that these cells should be called? I'm the first one. Nobody else noticed that in the literature. And here we are. You see there are 3? How do you expect them to be called? Yes, please. Yeah, they are lacunary. Look. I'm the first one who saw. Nobody in the literature has seen that. So what do you think they should be called? Please pay attention what you say. I'm the first one who saw them. Yes, please. Ah, thank God you put my name. That's right. We see there are three. There are three nuclei. See them. I'm not wrong. 1, 2, 3. Anyway, I'll report it to the hematopathology division, yes, of pathology. Okay, so what are these cells doing there? I don't know. I don't know. So what are they doing there? Look, all these eosinophils and possibly some neutrophils. What are these? These are not the neoplastic cells. These are the reactive cell population. Because the neoplastic cells are malignant cells, so they give a sign to the other cells of inflammation, of immunity, to go there and be the reactive cell population. If we have small biopsies that do not contain enough neoplastic giant cells, we are unable to make the diagnosis of Hodgkin lymphoma. However, if we find such a reactive population with some neutrophils, some eosinophils, we can postulate that something is happening, but we cannot prove it. In order to prove the Hodgkin lymphoma, you should have giant cells, neoplastic giant cells with CD15 and CD30 positivity. Okay? And in the classic form, CD45 negativity. And the last question in this lymph node with the nodular sclerosis, you see the bands of the fibrous tissue. The last question is, let me see. Here we have again, we have the malignant cells, yeah. If I can find that, I'll ask you. If I cannot find it, I cannot ask you. But I'll try. No, I can see here. I can see the malignant lacunar giant cells. But in this section, I'm afraid I cannot see what I wanted to ask you. Perhaps just a moment, because it's something. I found it. Now, have a look at this one. These are the neoplastic lacunar cells, probably. No, leave this one. Have a look at this. What is this? The fibrous tissue, all right? What is this? This is a nodular aggregate of cells, which I want you to examine, these cells here, and tell me if they are part of the nodular sclerosis classical Hodgkin lymphoma. What do you think this is? It is round. It has lymphocytes. Do you see any neoplastic lacunar giant cells? Neither do I. So what can this be? Who can tell me? It's easy. It's a nodular accumulation of lymphocytes. And we are in a lymph node. So what is this? What can this be? This is something of the normal structure of the lymph node that remained, that stayed there despite the distortion of the architecture caused by the nodular sclerotic lymphoma. And what is that from a normal lymph node? Yes, this is a lymphoid follicle. Rather primary, I think, because I do not see the blast center. So this is normal lymph node parenchyma, which is only in a just part of the section because the other part of the lymph node was destroyed. The normal architecture in the other part of the lymph node was destroyed by the lymphoma, the classic Hodgkin lymphoma. Yes. Now, next slide. Here is another slide of nodular sclerosis. Okay. We have another. I want you now to have this. Can you tell me what's wrong with this lymph node? Can you tell me? What's wrong? What do you see that it is not so consistent with a normal lymph node? Yes, please. The capsule, let me have a look at the capsule. If I can define where the capsule is. Oh, I'm not sure I can see the capsule. However, I can see that, what are these cells? Here, fat cells. So, there are some lymph nodes that have fat cells within the lymph tissue. This is okay. However, these cells being at the periphery of the section, what are they most probably? Where do they most probably belong? Do they belong to the lymph node itself? They probably belong to surrounding tissue. So, let's say that they belong to surrounding tissue, which they most probably do. What's wrong with them? If these are cells from the surrounding tissue of the lymph node, is there something wrong with them? Have a look. What are these other cells doing here? The other cells, these ones, the dark appearing cells, are, for example, we say that this may be the lymph node, all right? It looks like it. We'll see what structures are within the lymph node next. This might be the surrounding fat tissue. And what are all these cells doing here? What might you suspect if you see that? Yeah. Excellent. No need to come. No need to come on Tuesday. Just give me your name. This may be invasion, because you see lymphocytes entering the adjacent adipose tissue. Why? If they are malignant, you can explain it that they invade the surrounding tissues, like all malignant neoplasms do. How are all malignant neoplasms diagnosed? Atypia and invasion, generally. We're talking generally now. That might be the case here. So it does not prove that it is invasive, but it makes you suspicious. So now, we have this suspicion. Let's go in the lymph node and see if there is something wrong in the lymph node. Now, here is the lymph node. Do you see something wrong here? What structures are these? What structures are these? That are encountered, similar structures, are encountered in a normal or reactive lymph node. What structures are these? I'm sure you can identify them. There are the lymphoid follicles, and they appear to be secondary lymphoid follicles. I see the blast centers. Yes. What's the problem? The problem is that there are too many. They are quite big. Some of the blast centers are quite big, and they are throughout, everywhere in the lymph node, not necessarily in the B zone where we are expected to see them, but in any case of a lymph node hyperplasia, okay, they should be distributed throughout the lymph node. So, is there anything else that disturbs you? Let me show you and help you, because we'll make the diagnosis together. What do these appear to do? This one with this one. This one, have a look at these two. This one and this one. What do they appear to do? They appear to merge one with another. And interestingly, have a look at this follicle. What is this zone here? Which should be easily discernible in all reactive secondary lymphoid follicles. What is that there? There? How do we call this zone of B cells? The mantle zone. Yes. Is it throughout? No. If this is the mantle, where is it here? Where is it here? Where is it here? So there are some of these blood centers, some of these follicles have no mantle zone. This is abnormal. All right? Next, before we apply immunohistochemistry, all this is by morphology, taking into account the reactive lymphoid follicles that we saw in the dermatopathic lymphadenopathy. What are these cells different? How do they differ? The cells that we see in these blast centers, in these lymphoid follicles, by comparisons to the one we saw in the reactive lymph node. What's the difference? Can you tell me? Do you remember what we saw in the dermatopathic lymph node? Yes, please. They have no, louder please. They look all the same. They are monotonous. So, do you see those cells having the apoptotic body that we said they were reactive lymph nodes, so there was increased proliferation in apoptosis, and we had some macrophage phagocytosing the apoptotic remnants? No. Here we have a monotonous population of B cells where there are no signs of apoptosis, at least morphologically. So it's possible that this mechanism has been impeded. Possible. Something that would not happen in reactive lymph nodes, because in reactive lymph nodes, apoptosis should be functional. So, having all this morphology, taking all this morphology into account, we have to perform some immunohistochemical stains, so to see if this is a nodular type of lymphoma. Is it possible that it is Hodgkin lymphoma? Why? Because we look in these follicles and we see no giant cells, no Reed-Sternberg cells, no Hodgkin cells, no Lazarus cells. All right? Okay. So, it is not a Hodgkin lymphoma. It is a non-Hodgkin lymphoma. And being a non-Hodgkin lymphoma with a follicular pattern, do you expect it to be of B cell lineage or of T cells? If this is a lymphoma, and these are lymphomatous nodules, what are they possible to be? B cells or T cells? You think. What do B cells form in the normal lymph node? Follicles. So if we have a nodular lymphoma without the neoplastic giant cells of Hodgkin lymphoma, it is a non-Hodgkin lymphoma, then it is expected to be of B cells. Of course, we'll have the ones that form the follicles. In the normal lymph node, B cells form the follicles. So, this is probably a non-Hodgkin B cell lymphoma. It can be of low grade because, from a morphology point of view, most cells are small cells, and have a look at the distribution of the chromatin close to the nuclear membrane. Since these cells are of the blastic center of the lymphoid follicles, how are they called? Centrocytes. Some bigger ones, perhaps like this, bigger cells in hematopathology are called blasts. So these are centroblasts. Don't be in a hurry, because we have to explain them thoroughly so that you understand them. No hurry. Oh, okay. No, I did. I left the ones I didn't know for the last, so we won't have them. And I kept the ones I knew. All right? Okay. So, our markers. CD3, this is a T cell markers. It will have nothing to do with these lymphoid follicles. CD10, CD19 and 20, yes, because they're of B cell. Okay? Now, a marker that is consistent with the blockage of apoptosis and which will help us differentiate the lymphomatous lymphoid follicles from the reactive lymphoid follicles. Do you remember it from your study? An immunohistochemical marker that will help us differentiate the lymphomatous lymph follicles, which have no apoptotic potential, from the reactive lymphoid follicles, which have apoptotic potential. Remember that? Oh, no, that's another way. That's how apoptosis is performed, Fas and Fas ligand. Yes. Yes, please. Excellent. They express BCL2. These lymphomatous lymphoid follicles express BCL2, showing that there is no apoptosis. Okay? And another pair of markers is the one that tells us that this lymphoma derives from the center, the blast center. And this is CD10 and BCL6. So, to summarize, we have no classical lymphoma, Hodgkin lymphoma, giant cells. So it's a non-Hodgkin B-cell lymphoma. The lymphomatous cells do not express CD3, they are B cells. They express markers of B-cell differentiation, CD19, CD20. Cells deriving from the blast center, CD10, BCL6, and they express BCL2 because apoptosis is blocked. If it were a reactive lymphoid follicles, it would not express BCL2 because apoptosis would be functional in the reactive. So this is the nodular B-cell lymphoma, low grade of cells of the blast center. Now this one. This lymphoma does not have a nodular pattern, so we cannot tell. If it is a non-Hodgkin lymphoma, we cannot tell is it of B-cell origin, of T-cell origin, we do not know. It is not a Hodgkin lymphoma because malignant giant cells of Hodgkin lymphoma are absent, so it is probably a non-Hodgkin lymphoma, which we could not easily suspect as such because its cells are too mature. They are morphologically identical to normal lymphocytes. However, this monotony is not compatible with a normal lymph node. And here, what else, much more evident than in the previous case, is observable in this field? What else is observable here? That we can tell that something wrong is going on. You see a lymph node, you see no lymph follicles, you just see a diffuse population, you say, what is this? What do you see here that it disturbs you? What do you think? We've mentioned it in the previous lymphoma, but there it was not clear enough. Here it is clear, fortunately, so that we won't miss the diagnosis. Who can tell me? What do you see here? Yep. Yes, please. Yep. The fat cells being invaded, fat cells clearly outside the capsule, clearly beyond the capsule, that they are being invaded by those benign looking, deceptively benign looking small lymphocytes. So, you see here, perfectly normal in appearance, but of clonal nature. They have a clonal proliferation. So what do? We perform the markers. These are B cells, CD19 positive, CD20 positive. There is another immunohistochemical staining that when we have a B cell population which expresses immunoglobulin under condition that it expresses immunoglobulin, it may help us define its clonality. If it expresses, if there are B cells that they are mature enough that they express immunoglobulin, either plasmacytes or somehow mature, not being plasmacytes. What can this be? What can this be? Yes? Yes, but I'm not sure I'm familiar with this. If it is mature, what will it have on its surface, the B cell? Apart from that, what do B cells produce? Antibodies. It will have the immunoglobulin. So, if it is of clonal nature, and you have the light chains, immunohistochemistry, kappa and lambda, and it is of clonal nature, one type of light chains will clearly predominate the other. Whereas, if it is of polyclonal derivation, you'll have both kappa light chains and lambda light chains. So, this light chain restriction is compatible with clonality, with lymphoma. All right. And now that we have a low grade, because it is evident that it is low grade because the lymphomatous cells are too mature looking, are deceptively benign looking. What are the cells to diagnose this part of lymphocytic lymphoma, a low-grade B-cell lymphoma, which when these cells circulate in the blood, this is compatible with chronic lymphocytic leukemia. Because if we have malignant cells circulating in the blood, we diagnose leukemia. You remember these markers from the theory? From the small cell lymphocytic lymphoma, CD5, CD23, but not cyclin D1, because cyclin D1 positivity is compatible with the diagnosis of another type of low-grade B-cell non-Hodgkin lymphoma known as the mantle zone. The mantle lymphoma. Okay? So, what are these lymphocytic lymphoma, non-Hodgkin, non-Hodgkin lymphoma expressed? They express B-cell markers, restriction of light chains, and CD5, CD23. Okay? Deceptively benign, but of clonal nature. Lymphocytic lymphoma and leukemia if these cells communicate in the blood. Next, we have another diffuse lymphoma, like this one, which we cannot say if it is B or T cell, its origin. However, we can see that there is increased mitotic activity if we perform, have a look here, mitosis, if we perform, there is distortion of the lymph node architecture, it's a lymphoma, all right. If we performed the proliferation marker Ki67, it will be expressed in 99% of malignant cells. And also, these cells also have increased apoptotic potential And this is why you see this pattern here of all these cells. Let's have a closer look at them. Could they be Hodgkin cells, Hodgkin lymphoma cells? They appear somehow like lacunar cells. However, there is a morphologic feature in these cells which makes them innocent. What is that? Let me check some of them. Could they be lymphoma, Hodgkin lymphoma cells? This one, for example. Could this be? What does it lack to look a malignant cell? What does it lack? How do you expect a malignant cell to be? Yeah? Don't respond too quickly so that there is not enough time for me to show other slides and you'll have less. Pretend that you think, right? Pretend that you think. In any case, we'll finish the lymphoma slides, right? In any case. Yes? Yes, this is not the pleomorphic nucleus that we saw in the Hodgkin lymphoma giant cells. So, what are these? These are macrophages, and they phagocytose. What do they phagocytose here? The apoptotic bodies. And what does it make? What does this feature now look like? Because now that we have the summer nights, you'll go up on the terrace, and what will you see? You'll see, what do you see at night? When you have a break from your textbook studying? The stars in the sky. So this is the starry sky appearance, and the sky is the lymphomatous cells. That's why they appear dark. And the stars are the macrophages. This is a hallmark of activation of lymphoid tissue. This is not a hallmark, a morphologic picture of lymphoma. We diagnose the lymphoma because there is destruction of the architecture by a diffuse population of cells with increased mitotic and apoptotic activity. This is what makes the diagnosis of the lymphoma: the distortion of architecture of the lymph node and the clonality of the cells, of the population of cells. So we have to perform immunohistochemistry. This is of B cell origin, so we expect that CD19, CD20 is expressed, and since both this lymphoma derives from the blast center, despite being high grade, because with such high proliferation index, it's a high grade lymphoma, not a low grade, as we saw the case was in the follicular lymphoma, non-Hodgkin. However, since these cells derive from blast centers, which are the two immunomarkers that are expected to be expressed, in addition to CD19 and CD20, and the light chain restriction under condition that they have cephal immunoglobulin, as we previously said. Which is, no, BCL2 is the one that impedes apoptosis. No, BCL? Yes, these two ones, CD10 and BCLX. Sorry, BCL? 6. Okay, BCL6. Okay, and then we see the starry sky appearance, which is compatible with Burkitt's lymphoma diagnosis. But we would not diagnose the Burkitt lymphoma due to the starry sky appearance. Because any lymphoid tissue, reactive lymphoid tissue, that has increased proliferation, increased stimulation, increased proliferation, and increased apoptosis can have this pattern without being malignant. So that was Burkitt lymphoma. And I want you to ask you, now we have a high-grade lymphoma, B-cell, non-Hodgkin, like this one. And we had the previous one, B-cell, low-grade lymphoma. The follicular lymphoma, non-Hodgkin, the lymphocytic lymphoma. What does the pathologic grade of the lymphoma tell the clinician to do? For example, you have a low-grade lymphoma in an aged patient, which has some sort of other diseases at the same time. Is it proper to give high dose of chemotherapy for a low-grade lymphoma? No, because it won't work. Because being of low grade, the majority of cells will not respond to chemotherapy, and you'll have all the toxicity of chemotherapy. So in such cases, if it is of low grade and you have an old patient, just think to give nothing and just see how the disease evolves. On the contrary, if you have a young patient that has no other diseases and has a high-grade lymphoma, as the Burkitt lymphoma, then you think that you should give high-dose chemotherapy because there is a chance that you destroy all cells, because all cells have proliferation capacity, apoptotic capacity, and chemotherapeutic drugs work through these mechanisms. They target highly proliferating cells, or they induce apoptosis in highly apoptotic cells, in cells with high apoptotic potential, and they become self-destroyed. They destroy themselves. And there is another reason as well. Say that the patient can tolerate high-dose chemotherapy, and he has a low-grade lymphoma. Yes. You give high dose, of course it won't respond entirely, because there is a population that remains within the tumor and probably expands and does not proliferate much so as to be destroyed by chemotherapy. And after 5 years, this low-grade lymphoma transforms to a high-grade lymphoma. Why, if you give high-dose chemotherapy, then it won't be functional? Now it has transformed. That happens in 1/3 of such patients with low-grade lymphomas. Now the lymphoma has transformed into high-grade, so you could logically think that it would respond to high-dose chemotherapy. However, it does not respond. Why? Who can tell me? Thinking from a clinical point of view. Why? Because you started chemotherapy too early, and you didn't have a very favorable result, because you expected it not to respond, because it was low grade. However, the lymphomatous cells learned the drug. And what did they develop when they were transformed into high grade? They developed chemotherapy resistance. So, from a clinical point of view, how does the grading help us? If it is high grade, you think of giving chemotherapy, of course taking into account the toxicity possibility, but when it is low grade, you should be very conservative in what chemotherapy you should give, if any, if any. So that was a high-grade B-cell non-Hodgkin lymphoma. And here is another one, which is rather a diagnosis of exclusion, because we see a salivary gland, possibly parotid, being composed of acini, producing saliva, and ducts. Here are the ducts, the epithelial structures of salivary gland parenchyma. And what's the problem here? Large parts of the salivary gland parenchyma have been replaced by this small lymphocytic but quite dense and monotonous in appearance lymphocytic population. It may look like the ones we saw in the, where did we see this? In the Hashimoto thyroiditis, that we have a dense lymphocytic infiltrate. This lymphoma could apply to that case as well. However, if these normal B cells, normal appearing, but quite dense and monotonous cells are lymphomatous, having a look at this specific site of that clonal proliferation of that lymphoma, could you tell me, without immunohistochemistry, if it would be of B or T cell origin and why? What are these cells? Excellent. These are plasmacytes. So, if the clonal proliferation has cells that can differentiate to clonal plasmacytes, of course, it's a B cell lymphoma. So, all lymphomas with plasmacytic differentiation are B cell lymphomas. And the other feature here, apart from plasmacytic differentiation, is something that you see that makes you suspicious that something wrong is going on here, is where these dense lymphocytes expand. Where do they expand? And we can see them that they expand through the epithelial cells. That means they invade either acini or, in the present case, we can see them within ductular epithelium, because the epithelial components of the salivary glands are acini and ducts. So, when we see such lymphoepithelial lesions, you see how the lymphocytic component is admixed and enters the epithelial cells, the glands. Here we have the plasmacytic component. Here we have the lymphocytic component. In any case, if we see lymphoepithelial lesions, we have to examine the clonality of the lymphocytic population. Have a look here, the epithelial structures and the lymphocytic lesions, lymphoepithelial lesions, very, very dense. Can you show me the lymphocytic? I know. There's just, I know. Why are you tired? Why are you tired? There's one else and we finish. Fortunately, I left the nervous system. I didn't know them that well. Ah, sorry. So here are, so it's another lesson, and it starts at the quarter. That's what my direction is. Always start at the quarter, so it's no problem. So here, you see these? These are the epithelial cells. These are the myoepithelial cells of the duct, and these are the lymphocytes forming. How do you define them? They are more dark. Their nuclei are more dark staining than the epithelial cells. So these are the lymphocytes of the lymphoepithelial lesion. So this is a multilymphoma, a B-cell non-Hodgkin lymphoma deriving from mucosa-associated lymphoid tissue, multilymphoma. And immunohistochemically, you'll just know that the multilymphoma diagnosis is a diagnosis by exclusion. That means it does not express cyclin D1, it's not mantle lymphoma. This is a marginal zone lymphoma, B-cell lymphoma. And our last slide is mycosis fungoides, which is a skin lymphoma, extranodal lymphoma of T cells. And can you tell me the sign of malignancy that is evident here? This is skin. You see the epidermis. We'll see the epidermotropism, the entrance of lymphomatous cell within the epidermis, similar to the previous lymphoma, the multilymphoma, which that, however, was of B cell origin. But can you tell me which sign of malignancy you see here? Apart from that, this is a too dense lymphocytic population. What are these cells? Fat cells of the subcutis being invaded by the lymphocytic cells. So something's going on here. So let's have a close look at the epidermis. And what do we see? Here are cells, epidermotropism, that means lymphocytes entering the epidermis. Of course, this could just be exocytosis that would be relevant with some dermatosis. Yes, but in the present case, you see how many they enter? Have a look. These are the epithelial cells, the squamous cells, and this is the invasion of the epidermis by the T-cell lymphomatous population. So this is an extranodal lymphoma. Oh, look what's happening here. Look how they clearly invade, you see? See the lymphocytes? Oh, my. And you see how very dense. It has nothing to do with the sparse lymphocytic infiltrate so common in dermatopathies. So this is epidermotropism. This is subcutis invasion. So for next Tuesday, nor tomorrow, we'll have the slides of skin, endocrine gland, lymph nodes, just 3. And we left the nervous system slide and the mesenchymal neoplasm slides. All right? So we'll have these 3 system slides. So sorry, I didn't manage to have them, to present them all. Hopefully next year I'll manage. Bye now. Γεια χαρά. Bye bye. Bye.